Welcome to the SJMC Grand Rounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Okay. Hello, can you hear now? Testing. Input device, I don't see. Can? Okay, sorry. Sorry for the glitch. Let me just go through the just housekeeping slides. Please join us at slido.com at 3074245 for the Q&A, which will be the end of the session. And then the attendance would be presented at the end of the session as well for CBD points. So I'm going to hand over to Dr. Jayamala, all right, for the main presentation. So over to you, Dr. Jayamala. Sorry about the sound just now. Okay. All right, guys. Okay.
Thank you, Dr. Allen. This is our 41 SJMC Grand Rounds, as Dr. Allen mentioned. And we are from misstep to master stroke, diagnosing right from ECG. So Dr. Kannan, would you like to present the case first?
Thank you, Dr. Jayamala. So the first case is a 65-year-old diabetic who presented with a 2-week history of effort dyspnea. Someone with known chronic obstructive airway disease due to smoking and has had several admissions for exacerbation of his COPD. He now presents with a 2-week history of effort dyspnea. Next slide, please.
Okay, Dr. Thurston. Now, this patient is your patient. He comes to you. So just with a history like that, what are some possibilities as what could be wrong with him?
Yeah, thanks, Dr. Jia. So before we go into the clinical examination part in more detail, I think right off from the clinical history with frequent COPD exacerbation, that of course would be the top of the list. Could this be another acute exacerbation of COPD? There are also other respiratory causes that needs consideration, whether there's pneumonia, pneumothorax, any lung abscesses, and etc. That could also be in keeping with someone with possibly emphysema as a consequence of COPD. And there are also cardiac causes to be considered, and this could be acute coronary syndrome, acute heart failures, valvular issues, even heart rhythm problems and pericardial effusion require possible considerations. And let's not forget metabolic derangements, including metabolic acidosis, which can also present with symptoms of dyspnea.
So in other words, look at the patient as a whole.
Absolutely.
Kanan, you
So
like to continue?
when we examined him, he had bilateral leg edema. His JVP was elevated to the middle of his neck. Blood pressure was 140/90. We noticed that his heart rate was 42 per minute. In the lungs, there was bilateral expiratory rhonchi.
Okay. Based on this so far, what is your working diagnosis and what investigation, if any, would you want to do, Dr. Thurston?
Yeah. So I think the presence of leg edema and raised JVP in tandem with a very slow heart rate, I think top of the list in terms of investigations would be an ECG, looking at the ECG as well as the chest X-ray. We'll be thinking whether this could be a presentation of heart failure and whether there's any abnormal heart rhythm as well.
So this is the blood parameters. And would you like to comment on the blood results? Anything?
Nothing too striking, to be honest, from the blood test results itself. Hemoglobin is normal, slightly raised total white, creatinine is normal, potassium is a bit on the low side. Troponin T, I would say, sort of borderline, doesn't exactly point us to anywhere in particular.
Yeah, sometimes in patients with chronic illness, it might be raised and there not be anything wrong. So you asked for a chest X-ray. This is the chest X-ray.
Yes. So if we look at the chest X-ray, I think you can see this is quite a emphysematous lung to begin with. There's a bit of haziness in the right lower zone, but the heart size, I would say, is still pretty much normal.
That is the ECG we asked for.
So the ECG is rather interesting. I think when I looked at the ECG, the way I look at it is this a normal or abnormal? I think right off, you notice that this is an abnormal ECG. And the striking thing is that the ventricular rate is very slow. So the heart rate, ventricular rate, I think is in the region of 30 plus here. And if we look at the P's, you will notice that the P's are pretty much probably in the region of 80 plus beats per minute. And not every P is followed by a QRS. So what is apparent on this ECG is that this is a high-grade second-degree morbid type 2. Yeah, and there's also a pattern of right bundle branch block.
Okay. So your diagnosis?
Well, so this gentleman would, from the ECG, is high-grade type 2 AV block with RBBB pattern.
So what would you do and how would you treat him?
The first thing is to stabilize the patient. The heart rate is rather slow on the ECG. You'll be thinking whether there's an indication for a transcutaneous pacing. The blood pressure is normal, so you do have some time. You might consider, if the heart rate drops further, a dose of IV atropine just to stabilize him, or even an infusion of a dopamine if required, if he becomes unstable. The second possibility is that in the long run, this gentleman would likely require a permanent pacemaker.
Do you think there's anything, some medicine or something that you would have done which may have caused this?
Well, in terms of possible causes, you'll be thinking whether most common cause of high-grade AV block would be degenerative conditions of the conduction pathways, but you also consider any underlying coronary artery disease, cardiomyopathies are also possible causes. Medications, you really have to go back to the patient and inquire whether it's also taking any other things besides the ones it's told us, any herbal supplements, for instance. And I think we went through some of the major electrolytes. The potassium was a bit on the low side, but that probably wouldn't be the precise cause of this. Most likely still degenerative cause.
Yeah, I think I agree with you. So the learning point, I guess, is that the patient may come again and again with similar complaints. Somebody with COPD, oh my God, he's here again with difficulty breathing, must be another acute exacerbation. But we should never assume it is the same old disease. It may be another cause. As Thurston has rightly pointed out, it may be a pneumothorax. It might be some other thing, a pericardial effusion from another malignancy or something that he may have developed. Remember, smokers can get CA lung as well. Okay, moving on. Kanan, would you like to share with us your second case?
Okay. This is a 54-year-old lady who presents with recurrent vomiting in your clinic. She also complains of epigastric discomfort. She looks pale.
Yes, Nazrul. So with a history like that, what do you think?
Thank you, Dr. Lia. Well, I think the first thing that comes to mind is whether this could be due to some gastrointestinal pathology. So I think the first thing that I would think of is whether this could be a peptic ulcer disease. Things like acute pancreatitis can have similar presentation as well, and even gallbladder disease like acute cystitis. Of course, looking at her age, she's post-menopausal. I think we also have to entertain acute coronary syndrome as part of the differential diagnosis. And last but not least, I think metabolic causes also needs to be considered, things like diabetic ketoacidosis or acute renal failure.
So these, Kanan, would you like to continue?
All right. The clinical examination revealed a pale patient. Blood pressure was 170 by 100 is high. Pulse rate was slow at 32 per minute. The heart, we could hear a harsh sound throughout the cardiac circle, the left sternal edge. The lungs were clear to auscultation. In the abdomen, there was some epigastric tenderness. Next slide.
So this was your diagnosis, lah.
So initially, she was considered to have acute gastritis and possibly bleed. Okay. I suppose there's something in the clinical signs that tells us that the bleed is not likely.
Well, yeah.
What are the things in your clinical findings that raise alarm bells, Nazrul?
Well, I think the thing that stands out here, if someone is bleeding, you would kind of expect them to be tachycardic. But when you look at a pulse rate is only 32 beats per minute, which doesn't seem to be indicative with someone with volume loss. So I think what I would do first, I would probably get an ECG, then just to have a look and see what the heart rhythm is.
So this was a ECG that you asked for.
Well, I think the thing that stands out first, I think the ventricular rate is very, very slow. If you look at the distance between the QRS complex, I think the heart rate is about 30 beats per minute. The other thing that stands out...
For the purpose of the GPs, can you tell me how you calculated a heart rate of 30? Because they...
Okay, well, so what we did was we looked at the big box. Yeah, so we calculate how many big boxes there are between two R&R interval. So it's roughly about 10, and we divided it with 300. So we got about 30 beats per minute. The other thing that we look at, if you focus at lead 2, if you look at every QRS complex just before each QRS complex, you can see that some QRS is preceded by a P wave, some you don't really see a P wave. So the other thing that we look at is the T wave. The T waves are very tall and tented. I think these are quite commonly seen in patients with hyperkalemia. So that would be my initial diagnosis looking at this ECG.
Okay. So what do you want to do?
Well, I would get a full blood count in a renal profile immediately for this patient.
So her HB is 7.5 and her potassium is 7 with a creatinine of 650. So what would you do, Nazrul? I mean, most of us would just pack the patient off to a nephrologist, but what would you do?
I think in the acute setting, I think what we need to do is to ensure that she doesn't develop any malignant arrhythmia. So I think what I would give her is a lytic cocktail, which consists of calcium gluconate, That is to stabilize the cardiac cell membranes and to further prevent arrhythmias. I would give her insulin as well as dextrose. That is to try and bring down the potassium as fast as possible. And the other thing that we can actually do is to give her Ventolin nebulizers. I think that will also bring down the potassium immediately. But long term, she's going to need a dialysis, I think, to bring that down. Acute HD.
Okay, so you did exactly what they followed exactly what you told them to do. So this was the ECG after. Can you comment on it?
Okay, so now she's back to sinus rhythm. As you can see, she's got every P wave before QRS complex. The T wave has normalized. And looking at V4, V5, she may have a background history of hypertension. I'm not sure because there is some T wave inversion after V4, V5, and also the R wave is a bit tall, so she may have a background of hypertension. So I would say this is a fairly normal looking ECG.
Okay, all right. So the learning point, this ECG is you probably quite readily provided a clue to the diagnosis. So the ECG was faster to arrive at the diagnosis and to wait for the blood results. Am I correct?
Yeah, the other thing I think worth pointing out is all these cases that we are presenting today are real cases seen in our hospital. So this patient, when they called me, this is many, many years ago, they said patient is heart rate is very slow. The cath lab was called, pacemaker therapy was already prepared. So we could have run into trouble. So going back to what Thurston's ECG showed, where bradycardia, not every bradycardia needs a pacemaker. Some of them can be very easily treated, as in this case.
Okay. So yes, so Kanan's case again.
Next
There's a lot of cases today.
Working hard. Okay, this case is a 75-year-old Sikh lady. She's diabetic, fasting glucose at time of presentation was 8 millimole. She was also known to be hypertensive. And she presented with intermittent slurring of speech, which had been noted from the time she woke up in the morning. And she said she never had any similar past history. Next slide.
Yes, Thurston, what do you think?
Purely based on the symptom of slurring of speech, I think you'd be thinking of an ischemic cerebral event, most likely a sort of a TIA or an actual full-blown cerebral infarct. That would be the diagnosis to exclude the stroke, essentially.
So yes, Kanan.
So the clinical findings was blood pressure was 130 by 90, pulse rate was 80 per minute. Sorry. Clinically, the pulse felt regular. The rest of the examination was quite normal.
So was she able to talk quite clear when you saw her by the time you saw her?
Yes, would speak clearly, yes.
So she was a TIA.
Okay.
So, right, so what do you think? You have probably answered this already. So TIA. Okay, so ECG was done. Yes, Thurston, would you like to comment on this ECG?
Yeah, absolutely. So I think the striking thing of the ECG is that this is a regular pattern, irregular ventricular contraction. So despite the clinical finding of where the pulse was felt to be regular, an ECG actually proves the fact that it was atrial fibrillation. There are two possibilities for this. There is a paroxysmal atrial fibrillation. So at the time of clinical examination, the pulse is regular. Or sometimes the atrial fibrillation is at a rate where it's difficult to decipher whether it was regular or irregularly irregular. So anyway, ECG clinches the diagnosis of atrial fibrillation, and you'd be thinking of a cerebral sort of emboli as a consequence.
So why is it so important that to make a diagnosis of AF, Dr. Thurston?
Yeah, absolutely, because atrial fibrillation increases the risk of stroke, and we all, without going into too much, you know about this Charts-Bus score, and we know about the association with blood clots in the left atrial appendage and etc., which predisposes patients with atrial fibrillation to stroke. And it's important also that we look at other things, not just the atrial fibrillation ECG, things like blood pressure as well, I would say.
So you make the diagnosis. So the learning point that you wish to make?
I think it's ECG being a basic tool is pivotal on top of the clinical assessment. In fact, it's part of our clinical assessment, particularly in this case where, again, when pulses felt to be regular, the ECG shows atrial fibrillation.
I guess anybody with transient or episodic neurological signs, an ECG is very important. And sometimes you may even want to do a Holter or prolonged monitoring to exclude a paroxysmal arrhythmia. So I think.
Maybe one other point, since we're discussing ECGs and neurological events, we have had over the years occasional patients who present with a classical cerebrovascular accident. And for all intended purposes, all investigations show that the patient's in sinus rhythm. But when ECG is done, it shows an acute myocardial infarction. And what happened was that patient had infarction, developed a mural thrombus, and the thrombus ran off, causing a stroke. So that is another thing that the ECG will help in the management of patients presenting with a cerebrovascular accident.
Okay, Anand, again.
Okay. So the next patient is a 57-year-old hypertensive who presents with severe backache. Blood pressure is 200 by 100. Pulse rate is 100 per minute. There is some tenderness elicited in the lumbar area. The rest of the clinical examination is normal.
You would like to comment about the ECG, Nazrul?
Okay. Well, the first thing is that this patient is in sinus rhythm. And the striking thing here, if you look at the R wave, if you focus on V5 and V6, it's got very tall R waves, yeah. And if you follow the Leon-Sokolov criteria, I think this fulfills left ventricular hypertrophy. And what you can see, I think the other thing is in the lateral leads as well as the V4, V5, V6, you can see the very deep T wave inversion, which is in keeping with LVH changes. There's also isolated PVC that's seen here. So looking at this ECG, I would say that this patient has got long-standing hypertension that's probably not been very well controlled.
So what is the association that you're thinking about? I mean, his problem was backache, and now he comes with this severe blood pressure. I mean, is there any association, or it just happens to be coincidentally he's got backache and swell, now he's got severe uncontrolled high blood pressure?
I think looking at this ECG and the fact that he's coming with lower back pain, I think the most important thing to ensure is that he's not having a life-threatening aortic dissection. I think that's one of the most important things that we need to ensure. Having said that, I think there are times as well that when patients come in with any form of pain, it can also lead to high blood pressure, I think, which is quite commonly seen in ER.
So the blood pressure is actually a reaction to the pain.
To the pain itself, correct, yeah. So, but I think based on this case, looking at the examination where we see there's absence in parts of the left lower limb, I think the thing that needs to be considered is whether he's having an aortic dissection.
You can go back one slide there. This one is very interesting. I still remember him, this coming to ER, this is probably about 20 years ago, this slide. The ER medical officer actually diagnosed an acute intraseptal myocardial infarction. This was in the days before primary PCI, and we were giving streptokinase in our hospital, and streptokinase was actually being prepared. Would have been a major disaster.
Just now that you brought this question about AMI, why do you, I would say this is definitely not AMI. Why do you need and how do you distinguish it from an AMI? I guess there was ST elevation, but is this a typical ST elevation that you see in Nazrul?
I think because you need the ST elevation to proceed immediately beyond the J point, so you don't see that ST segment going up immediately. It's a bit concave.
Yes. So this is unlikely. It should be the other way around.
Yes. Yeah.
So you would not put it as
one simple way of differentiating probably is to just get an echo machine and quickly see what the interior wall is doing. It shows LVH and there's equal contractility, then we know that we're not barking up the wrong tree.
Okay, so somebody was very, very careful listening to what Nazrul said. Would you like to interpret this, Nazrul?
Well, you can see on the picture on your right hand side, you can see he's got, this gentleman actually has got an aortic dissection that's extending all the way from the arch, before the arch, from the ascending aorta all the way down towards the descending aorta. So I think the one that's highlighted, the brighter color is the true lumen, second, and the darker color is what you see is the false lumen, where there's contrast going on. So this gentleman needs urgent surgery to be done. He also needs his blood pressure to be brought down immediately to prevent worsening of his dissection.
Yeah. Okay, so yes, that was a case of aortic dissection, which we helped to make the diagnosis. Okay, this next case is for Kanan. Okay, 42-year-old man, very common scenario, presents at 9 o'clock at the clinic with epigastric discomfort and vomiting. Whole night he's been vomiting, cannot sleep. Sometimes get worse, sometimes get better, takes his control lock, and he's some relief. Then he starts it again. Long history of GERD. So he's just coming to your clinic to see whether he can get an injection. Non-smoker, no past medical history of no sweating or shortness of breath. Nothing to find on examination except maybe the BP a little bit high. Could be because he's a bit distressed, not sure. So what would you do, Kanan?
So maybe I want a few more findings in the clinical examination. Was he pale? Was he jaundiced? In the examination of abdomen, you say there's mild tenderness. Sorry, it was soft. Was there any tenderness?
Abdomen was soft, but he was looking so miserable. There was no pallor, there was no jaundice. He was looking really miserable.
So, of course, here we would think of someone who has got pain, recurrent vomiting, has got a background history of gastrointestinal problems, GERD. So, probably it is the GERD. Probably he has got peptic ulceration. Other things that one want to consider is whether this could be something related to renal disease that he might have developed. He's not jaundiced, so it makes liver disease less likely, but that's something I would want to consider. Whether he took something wrong in his food, whether this is food poisoning. These are the initial things that will go through my mind. So because of his symptoms, certainly want to do an electrolyte examination to make sure that that's not abnormal. It also enable me to know what his renal profile is like. I would probably also run a liver profile. Want to make sure that this is not pancreatitis, so I want to do his amylase levels. This is what I would initially do. He's not diabetic, isn't it?
No.
Must admit that I won't rush in and do an ECG for this man yet.
Well, in our ER now, it's a standing order that anybody who comes in with epigastric chest discomfort and vomiting should have an ECG.
Okay, that's good for them. So this ECG certainly is abnormal. It shows changes suggestive of hyperacute enteroceptal myocardial infarction, especially in V3 and V4. We can see it's really taking off. The T wave is very tall, the ST is going up. It's really very, very acute phase. To complement it, I would do a bedside echo that I'm sure that's going to confirm that the anterior wall is not moving. And if that's the case, then the lab has to be alerted and he goes to a cath lab.
Okay, this was his TROP-T and his CKMB result. This is not in keeping with an MI?
It's probably very early, so all these numbers will take a little while to change. TROP-T, I think even the most sensitive now takes about 2 hours. MB probably will take about 4 hours before we see any change. So if it's very early, we might not catch it.
So Kanan has said what he would do. So, well, they repeated the ECG while waiting for Kanan to come from the house. And what do you think now, Kanan?
Here, no one will disagree that it's an acute enteroceptal myocardial infarction and that he needs something to unblock his left anterior descending artery, which is closed off.
So what is your learning point, Kanan?
When someone complains of we've been told this over and over again, epigastric pain has always foxed us. We've always missed coronary syndromes and misdiagnosed them as get an acute gastric event. So, like you said, now it's a standing order. Epigastric pain, get an ECG done.
And the other thing is, usually they would say if it's an infarct, if they present with gastric symptoms, it's more likely to be an inferior infarct, but that's not necessarily true. It may even be an anterior. Okay, Kanan, back to you.
Okay, this is case 6, 40-year-old female, presents with breathlessness, no history of cough or chest pain. The person is known to have diabetes and hypertension, getting treatment from Kementerian Kesihatan Malaysia. Next slide.
Yes.
Okay. So clinical examination shows elevated jugular venous pressure up to the jaw, so it's very high. There's bilateral leg edema. Pulse volume appears to be low, and the pulse appears to disappear every time she's breathing. Heart rate is fast at 110 per minute. Blood pressure is borderline 100/80. Auscultation of the heart did not reveal anything, and the lungs were clinically clear.
You seem to imply low pulse volume appears to disappear during inspiration. What are you trying to suggest?
That every time the patient breathes, there's no pulse. I'm not suggesting anything yet.
Okay, I'm going to ask you this question later. Okay, Dustin, maybe you can tell us when you get something like that, what do you think is your clinical diagnosis? What would you want to look out for?
I'll say there are certain sort of mixed findings in this case, but the definitive findings of a raised JVP leg edema raises the diagnosis of heart failure, whether that's acute or acute on chronic. Surprisingly, the lungs are clear, so that's something very important for us to consider going forward. It's also tachycardic, and the blood pressure is borderline low. So I think to begin with, this patient is in failure, requires further evaluation.
Okay, now what are the possibilities? I mean, that you say lungs are clear. You pointed that out, that the lungs are clear, but yet he has signs of heart failure. What are possibilities?
Yeah, so I think top of the list would be a pericardial effusion. There's something called a Beck's triad, where you raise JVP and at the same time tachycardic, and you have muffled heart sound. So we don't have the finding of muffled heart sound up front in this case. But again, the low pulse volume which disappears with inspiration is quite key.
So some kind of pericardial thing, maybe effusion, maybe constrictive pericarditis, or some pericardial disease. What about lung disease? Do you think a lung disease could give rise to some of the symptoms?
Yes, possibly, but the lung findings is clear, and I presume equal on both sides reduces that possibility.
It could be pulmonary embolism as well.
Oh, yes, certainly.
Okay, all right. So this was the initial diagnosis. So they did an ECG, and what do you think of the ECG?
Okay, so first thing, this patient's in sinus rhythm, heart rate maybe in the region of 90 plus. If you take 300 and divide by 3 big boxes, and just a little longer than that. Striking thing when we look at the ECG is the fact that the QRS complexes are small. So when we say small QRS complexes, this is for the benefit of the audience, it means that in the limb leads it's less than 5 millimeters. In all the precordial leads, less than 10 millimeters. So that would be low voltage QRS complexes or small QRS complexes. So at this juncture, in keeping with the earlier clinical findings, you'll be thinking of pericardial effusion. And from a discussion standpoint, other possibilities are an oral myocardial infarct. Someone with COPD with emphysema will also have low QRS complexes. The pneumothorax can have low QRS complexes. And let's not also forget rarer causes like infiltrative cardiomyopathy.
What What about, we said possibility of pulmonary embolism. Would this in keeping with pulmonary embolism?
I would expect the patient to be more tachycardic. That would be the commonest ECG finding in pulmonary embolism. Of course, we also talk about classical patterns like S1Q3, T3, which is not present in this ECG. And don't forget, the commonest ECG finding still finds tachycardia.
Okay, so this is the patient's chest X-ray. Tested.
Okay, so yeah, the heart certainly looks enlarged in this chest X-ray. CTR ratio definitely more than 0.5, and you would think that this is what we call a slightly globular-looking heart. Now, of course, for those keen eye in the audience, you will notice that something has been done for this patient. There is a tube in the pericardial space. So this would be a chest X-ray taken after intervention. That's pericardial tapping.
What is the test? I mean, of course, you did all this, the chest X-ray, but what would you do to make the diagnosis?
The bedside echocardiogram.
So an echo is very, very helpful. So what do you think this case, any learning points from this case?
Yeah, so I go back to clinical finding. I think I would highlight the backstride again, that you have raised JVP, someone with low blood pressure, muffled heart sounds, overnight. In this case, I think 2 out of 3 raises the possibility of pericardial effusion.
Sometimes, what about if it was hypothyroidism, mixed edematous heart? They also can get a bit of pericardial effusion.
Absolutely. And then you look at the clinical demeanor of the patient. If they look a bit obtunded and etc., that would be a full-blown mixed edema crisis.
Okay, so Kanan, you're coming on
Case
to your
7.
case, your 7th case. He's presenting all the cases today,
6
man.
case today.
We're working very hard.
Boss giving me extra points, end of the year with bonus.
Yes, we'll give you extra CAPD points.
So this is a 28-year-old male. There was a history of a fracture of the femur during a motorbike accident. He had a long leg cast. He's a known asthmatic. And then he comes with sudden breathlessness. Blood pressure is 90/60. Pulse rate is 140 per minute. It's regular. And there are expiratory rhonchi in the lungs. So the ER diagnosis is actually acute exacerbation of bronchial asthma.
So Nazrul, they did an ECG.
Because the heart rate was fast. Yeah.
So I think the glaring thing here is the heart rate is tachycardic. His heart rate is about 150 beats per minute. The other thing I think that we can see, if you focus on lead 1, you could see that he's got a very deep S wave. And if you look at lead 3, he's got a deep Q wave, and he's got T wave inversions in lead 3. Now, of course, when we really interpret an ECG, you always have to do it in the context of the clinical presentation, and then considering this patient's past history of recent fracture, he's been put on a cast, so that itself can actually cause blood clots to form in the leg, and that could also lead to pulmonary embolism. The other thing that we look at is the patient's blood pressure is a bit on the lowish side for a young man. So generally, when someone comes in with acute exacerbation of bronchial asthma, you wouldn't expect them to be hypotensive and so tachycardic as such. So I think I would be thinking of a pulmonary embolism in this case.
What about the heart rate being so fast? I mean, it's 140. Is that in keeping with an asthma? Do they get so fast heart rate?
They would be tachycardic to a certain extent because of the sympathetic drive, because they're breathless, but they should not be this tachycardic beyond 150 beats per minute.
So your diagnosis was possibility pulmonary embolism.
Yes.
So what would you do? How would you clinch the diagnosis? Thurston.
Well, a few things you can do, but the one that clinches the diagnosis, of course, is a CT pulmonary angiogram. On the bedside, you can sometimes do an echocardiogram. It's a quick one to see if the right side of the heart is dilated. That's the simplest.
So would you like to interpret this CT?
Okay, I'm no expert, but if you look at the Yeah, so that where the cursor is, that's exactly where the blood clot is. So that would be the right main pulmonary artery, and the left also.
So both sides is here.
And maybe Jed, for the audience, just point out which is the pulmonary arteries.
Okay,
They
so
may not
this is
know.
the aorta here, which is right and round, and coming, this is the main pulmonary artery. This is the right, and this side would be the left. Okay, now this would be the left because the heart is here, and this side would be the right. Yeah, I'm sorry, yes, correct, because the descending aorta is here. So this is the left, and this is the right. You're right, Thurston. So this clot is in the main pulmonary, right pulmonary artery, but you also do see some clots here at the back. Okay, so this is the left because the descending aorta is here, and that's the ascending aorta. All right, so thank you all. So we finished a bit
early
early.
today.
Yes, so maybe that gives you more time to ask questions. Just a few things. This is, as Dr. Ellen has pointed out, we started way back in September of 2020. That was just at the peak of the COVID era. And today we are at round total 41.
Yeah, well done. Yeah.
I think we must thank all the people who have contributed. That included the cardiologist, okay, as well as non-cardiologists, some of our doctors, including the great Ellen here, and some of them were non-doctors as well. This is Kuhen, a physiotherapist, and this was our dietitian. And of course, we must thank the hospital administrators who helped to organize the CME, and of course, not forgetting the great Mr. Dobbs himself. And that's him. That's it. Say what?
No.
So after 41 case rounds, we thought we'll take a break for a little while before we recommenced this. So we'll pass it back to you, Ellen.
Oh, and thank you for the kind words. And I think I'd like to thank you and the cardiology team for tremendous stamina. I mean, I think it's been quite an effort, and I think it's reasonable to take a short break, and we'll need to recharge our batteries, and hopefully we'll see what comes out. It's just early days in the CBD cycle, so we may have something maybe in store for you guys. So I think we all thank all of you all for actually also attending, because without your attendance and feedback also it's quite meaningless, right? So I think thank you for all those who have attended our webinars and have given positive feedback, and that's very good encouragement. We have a lot of young doctors and specialists in SJMC. I hope they will come forward, because I think everyone here has this. A lot of people have this perception in the private hospitals see run-of-the-mill cases, but it's not true. Actually, we see some pretty interesting and very complicated cases, which I think is worth sharing with everyone, including the GP, so you can see actually how medicine is advanced. And I mean, for those who graduated maybe 30 years ago, they've not been exposed to new modalities or investigations, tests, and so on. So I think it's something which I hope we can carry on. But anyway, I think we better go on to the Q&A. So I will remind you all to go to Slido. I think there is there are a couple of questions on Slido. Both questions from Kashap Nair. First question he asked was, what did you do? Would you do a NT-proBNP for the patient to perform to exclude the CCF? I'm not sure which patient is referring to.
Which patient are you referring to?
Kashap.
MIC. Mic is muted. Well, I'm not sure which patient you're referring to, but generally you would do an NT-proBNP to sometimes confirm your clinical diagnosis, but if the diagnosis is clinical. And number two, we just sometimes do it to follow up the patient, that means to monitor the patient and to see how well he responds to treatment rather than as a diagnostic tool. The diagnosis is almost always clinical, unless occasionally we need an anti-pro-BNP to tip it whether this is actually an acute bronchitis or is actually acute LV failure.
The other question was, is the patient with epigastric pain, if he sees you with epigastric pain related to food, no sweating or no dyspnea, would you still do an ECG?
Well, I think the answer to that is, if the patient were to have taken all his normal antacids and is not getting better, then I think it's justifiable to do an ECG. The other reason why sometimes I've just seen a patient who had epigastric pain and he related it was due to some, and vomiting, which he said was due to some Japanese food he took the night before. But actually it was secondary to an acute liver congestion from heart failure. So once we gave him Lasix and his liver became less congested, the vomiting stopped. So I think if it doesn't respond to the usual medication, I think ECG is probably going to be very helpful.
I think to some extent, our decision making would be also related to what risk factors the patients have. I suppose a very young person, no risk factors, reasonable for us to treat it as an acute gastritis. But people who are slightly older, now young means very hard to define. People who are in the 30s coming as an infant.
Yes.
Especially if they got any risk factors like they're smokers, if they're diabetic. Diabetics can just present with vomiting as a first sign of acute coronary syndrome. They'll have nothing else. So I think we have to err on the side of caution. ECG doesn't take long to do. It's quite cheap.
Okay, the reason why they put it as a standing procedure in our fact that anybody coming in with some epigastric discomfort and vomiting, you have to do an ECG, because when we looked at our door to needle time and those STEMI cases that were a bit delayed, it was mainly the fact that the diagnosis was delayed. And that was because the patient had presented with vomiting, and so they were looking at other things rather than to do an ECG. So that's why anybody comes with vomiting, and that includes females. In fact, we had a female who came in just with vomiting, and they were treating her until suddenly the BP crashed, and then they did an ECG, and actually it was an acute infarct.
Okay, yeah. So these are interesting lessons. I think those very interesting 7 cases each have individual teaching points, which I think would be lessons to all of us, not just GPs. Yeah. Okay. We go back to the. All right. I think the moment everybody is waiting for, which is attendance link. So this is the link to scan with your normal scanner, not the MMA. MMA, there's no more scanner. So just scan to get to the registration form. Let me see if it's working. Then if you submit it, the SJMC team will upload the points within a week. Yeah. It's working.
Okay, Ellen, thank you very much, and thank you very much to all my colleagues and of course the audience for all their feedback and their positive thoughts.
Okay. Yeah. Righto. So if you have problems submitting the form, please contact the SJMC coordinator, Amy, and we will, or just leave a comment in the video, and then we will help you. Okay. Otherwise, we'll see you in the next one. We're not sure when the next one will be, but you stay tuned in the DOPS forums, and we'll announce and let you know. Okay. So for now, thank you everybody for attending. Thank you to the team once again for your excellent presentation and discussion. And have a happy weekend, everybody. Bye-bye.
Thank you. Thank you. Bye. Bye.